and now the next case, Dr. Ahmed will present the clinical, and there is Dr. Alia, Associate Professor of Clinical Neurophysiology, will present the EEG, and Dr. Michael will present the MRI.
Assalamu alaikum. أنا الدكتور أحمد عبد الرحمن. I'm Dr. Ahmed Abdurrahman, neurologist, currently training in Epilepsy Unit, Cairo University, as a part of International League Against Epilepsy Fellowship. Our case today is a 40 years old female, married and right-handed, with no consanguineous parent and negative family history. Sorry, her maternal cousin has epilepsy, mostly gets generalized tonic seizure, with an remarkable prenatal and developmental history. Past history, she has chronic common migraine with history of drug-induced cholestasis by phalobrate, and there is no history of no history suggestive typical demyelinating syndrome. The age of onset to any 8 years old. Semiology, aura, there is a sense of fear and epigastric rising. After that, she lose of awareness with then oro-elementary automatism, and then the left upper limb automatism to bilateral gestral automatism with head turn to left, with the left nose whipping, really evolved to bilateral tonic-clonic. The duration of seizure is from 1 to 3 minutes with post-ictal confusion. Frequencies of seizure, الفوكال aware الأورا from 2 to 5 per month, الفوكال and aware 1 per month, and الفوكال to bilateral tonic-clonic rare last 1 year ago. Triggers by catamenial and sleep deprivation, and there is no history of status epilepticus and no clustering. Longest seizure-free period is 1 month. Our seizure type is focal to bilateral tonic-clonic. Currently, the patient on three anti-seizure medication, levetiracetam 3 gram per day, and lamotrigine 350 milligram per day, topiramate 100 milligram per day. Examination, general examination is normal, and neurological examination also normal. This is semiology recorded in AMU. Unfortunately, we don't have a good quality home video. Yes. She has lip smacking, left upper limb automatism, with the right hand mostly a kinetic. Raw elementary automatism. She has bilateral automatism. Rhythmic right upper lip movement. Manual automatism by left hand. Head turn to left. Nose whipping by left hand. You go to tonic. To bilateral tonic. Clonic. Yeah.
Don't show the EEG yet.
Okay.
Wait.
Waiting for your comment on semiology.
Yeah, we have to guess, right? So can you hear me? Okay, so from the history alone, I love the history. Very classical aura onsets that sound like a classic mesial temporal, right? There's from what you're describing, the rising sensation and so forth.
Lateralization.
Yes. And then as far as lateralization, based on what you see, there's a trend, I think, as Dr. Geyer was saying, that it's a lengthy period of time. So we want to look at what clues we have clinically at the start of the seizure versus how it evolves. And what I noticed in the beginning, as you were saying, the right hand is relatively still. The right hand is relatively still in the beginning. Yes, and there's much more spontaneous movement of the left, which would imply then that maybe the onset is sort of more of a left temporal onset. And as it evolves, definitely there's much more picking of the bed sheets with the left hand. Yes, and then the nose wipe, as you said. So that would kind of suggest that later you might be getting toward the other side. But Fred, yeah.
I think that's perfect. But I think, I mean, the head deviation, the eye deviation is too late to make that lateralizing. But the hand wipe is ipsilateral, right? So everything you state suggests left onset. I would just be a little bit aware of things with also a sense of fear. You have to think of insula, you have to think of cingulate, and sometimes you have to think of posterior cingulate. But so it should be mesial temporal, but it could be, and it should be temporal. It's in the temporal lobe for that one. Yeah, skips. Now we'll find out. There should be something in the left mesial temporal lobe or the left insula, and it should be operable, and she should be seizure free.
Shall we start at the EEG? Okay.
Yeah, I might also add, in terms of her medicines, unless it's tolerated, I think the lamictal could be increased substantially.
Yes. The EEG was done for 3 hours during wakefulness and sleep. The interictals was left. Okay.
We don't see it yet here.
هيتعرض هنا ولا لا؟ شكلها بس متأخر؟ لا بس الصورة في افتراض الإدارة أنا أصلا بطلع عندهم. لا هو ده بتاعي أوكي ولا إيه؟ Left anterior temporal. Actually, it appeared 4 to 5 times during the 3 hours. The actual regarding the semiology, Dr. Ahmed presented it, but actually the EEG didn't show any actual onset. Shall I present the EEG with the semiology or the EEG alone? Okay, this is the clinical onset, this mark. Okay. The patient was awake during this. It occurred just at the beginning of the record. This is the first epoch.
Oh, he wants to see baseline. If you could go back.
Yeah, that's my question. I want to see the baseline.
There.
No, this is not the beginning. Stop. Yes, this is the background before. It's just 4 or 5 seconds.
First week.
Yes. Continue?
Yes.
Okay.
No problem.
Is there some feedback in the left temporal and the right temporal?
It looks like muscle to me.
Is it muscle for you?
It doesn't look like typical beta.
Dr. Kobesi sends his regrets, but there's a spike in the left anterior temporal, and there's greater attenuation across the left and the right. But the field is widespread, and it doesn't give you the typical onset for a mesial temporal seizure. So, and the fact that both sides are involved early on makes you nervous that you're missing something or may miss something. But the left side is more attenuated and has faster frequencies, so it's a left focus. I would pause it.
Okay. Continue the EEG.
And it's always the first second that gives you your answer.
This is during the automatism.
So it's bilateral, but this is more temporal signature. So it's spreading to the temporal lobe.
Here, the bilateral tonic-clonic started.
Yep. And now the answer will be in the MRI. So what happens at our conferences is Dr. Kobesi spends half an hour on the EEG, and I spend half an hour on the MRI.
Dr. Michael?
So what do people think in the audience?
I think it starts in the left mid temporal, and then it extends to the frontal, its lateral, and then the opposite side.
Any other views? There's a red dot in the middle of the brain. See, it's
So I will talk about imaging in brief. We did 3 imaging, one in 2021 and 22 and 25. The first one we saw we saw typical lesions of MS with central vein, and then on the follow up we had 2 more lesions, and then these are the red lesions, the new developed lesions, and then now we have another lesion. So the first MRI, no. So I have all the images with me if you want to check them.
So is it possible to go through
Yes.
the images more sequentially? And of particular interest is looking at the left. That's great. Slowly. Start at the back.
So we checked the left mesial and right mesial, of course. Now,
Just have to.
from here,
Okay. Well, let's go back again. Ooh. Slowly, slowly, slowly.
Yes, yes.
Nice. So what's the signal in the insula? Which is also
This.
a little bit more anterior.
Yes.
Go back up superiorly slowly. Stop in the, go back down, please. Down. Now, so what I'm looking at is whether or not the cortex is thicker in the mesial anterior temporal lobe on the left, and a little bit brighter. So on the coronal flare, yeah, go back, please. I'm sure this is fascinating for everyone in the audience. So the person might have lice and fleas. So how was the MRI interpreted? See, that's too big and too bright in the mesial left temporal lobe.
Yes, I know, but it's not. This is a common actual thing here in the mesial with the insula. You can see this.
Yeah.
All of these. This is a mesial artifact, not a real lesion. And you can, it's a very accentuated here. Can you see it?
Right, but it's if you look at the T2 axial image.
Mm-hmm. T2 axial or flare?
Axial.
Here.
So the comment being made is you have to be a little bit careful about flare imaging in the mesial cortex because there can be signal intensity just from as an artifact of the flare imaging.
Yes. And I tend to use T1 as it has more superior gray-white matter differentiation. So you can see them clearly here and there. Because in the flare you can see blurring, always blurring. But here you can see it, definite. Preserved.
And now, but right in there, okay. Okay.
Again, you can see it here. Now in the flare, if you have two cortices like this, you interpret them as thickening. That's the trick here. Like this. These are one cortex, another one, and another, and another. They coalesce together here. So you can see it as one big chunk of blurring. Now, if we check the T2, you can see the white matter is dark. It should be. Now, this is more of a partial volume effect.
So I think you mentioned you had marked the lesions that were new. Is that what that was? You had previous
Yes.
MRI and then you had additional T2 lesions.
So the problem we had, or we find, so we always find T2 lesions in every patient, and in normal we know that, but the distribution here was not typical for the non-specific lesions, if you may say. So we found something like here in the corpus callosum, and we found we found a lot of periventricular lesions. So this is the corpus callosal lesion. We have something in the thalamus, and you can see a little bit here and there, and juxtacortical. So we checked the central vein, but this was in 2021, so it was not in the criteria for diagnosis, but we did it anyway. Now we find some central veins like that. And here we can find it.
So there's, I think you may know, there's a lot of interest in using central vein sign to help us with the diagnosis of MS. We know
Yes.
many times you do MRI scan, they're white matter lesions, T2, and we're never sure is it vascular or demyelinated. And as you may know, multiple sclerosis, we believe, is focal inflammation. The immune cells will breach the blood-brain barrier and create these very characteristic MS lesions. That's why they're often linear and flame-shaped, because they track the vessel. With better imaging, you can find that vessel in the center of the lesion, and we believe it may be highly specific for multiple sclerosis. I think there was an interesting comment Dr. Gard was making. Initially, the story, I guess, for you guys was, oh, this is going to be a classic, temporal lobe epilepsy, kind of that presentation. But then you said something, oh, it's not doing that. It's almost like spreading to the temporal lobes. And so then it does, we mentioned earlier, we do see an increased prevalence of epilepsy associated with MS. So maybe it's a subtly different condition. Somehow the MS and the inflammation that, I guess this patient is undiagnosed and untreated for MS,
Yes.
could have active disease. And what if that led to a seizure that in a way mimics what you guys are used to as an idiopathic temporal lobe epilepsy? Because you guys seem, it doesn't have the look and EEG appearance of the very, very classic coming out of the hippocampus, the parahippocampal gyrus MRI. And so it does look like this could be a case of MS leading to
So
seizure.
yes, we are. Any comment about this? So I can do the follow-up. Can I show it? Okay.
Please.
ممكن the patient was diagnosed as focal epilepsy when she was 28 years old, and she was focal epilepsy responsive to single anti-seizure medication. 6 years later become drug-resistant epilepsy, and we revise the diagnosis and do first, unfortunately, in 2018, but we didn't have the film, show suggestive MRI suggestive radiological isolated syndrome. After that, we searching for multiple sclerosis clinically and history negative. We did CSF with the positive longitudinal band and IG index elevated, and VEB was normal. At that time, we didn't do anything, just anti-seizure medication modification. And follow-up patient in February 2021, also there is the same pictures. Another times in 2022 we do MRI and VEB, also the same with the new lesion. At that time, in June 2022, also it was off-label. We give the patient 5 days IV methylprednisolone without improvement in seizure frequency. Okay, new imaging. The last imaging is in
Okay, so now we are scrolling through.
spine.
So any comment? I'm scrolling.
On the opposite side become more evident near the right side.
Okay. The Dawson. Ah, okay. Sorry, show you that. So you need to see it in the flare and on the sagittal here. Yes, I know. It's very convincing here. So you can see there is a difference in the lesions, in the scans, and in the current, and the very recent one. Here is a recent one. So one lesion appeared here. It wasn't there in the insula. And I will just cut short right now to the spine. And you can have another one here. So the symptom was fits. So what do you think?
Hypothesis. Our hypothesis is mesial temporal, mostly left, but it's not highly lateralizing. Interictal EEG was left, and diffuse ictal EEG and MRI, as you see. Drug resistance epilepsy can be presented as multiple sclerosis can be presented as seizure. There is a case report of 2 cases in which the first cases was isolated DRE with focal aware seizure, and MRI showed suggestive demyelinating lesion with the focal electal EEG was left temporal, and she was operated pathological by anterior temporal lobotomy. Pathological finding, there is demyelination, and the patient become seizure free. Another case, she was focal drug resistance epilepsy. MRI shows with negative clinical and oligoclonal band was positive. Interictal was bilateral independent temporal, and ictal EEG was diffuse. They tried off-label treatment with natalizumab. Unfortunately, drug resistance epilepsy persists, but MRI lesion improved. the incidence of multiple sclerosis, as Professor said, it is higher than general population with 2 to 4%, with majority of seizure coexist with clinical multiple sclerosis. Epilepsy as isolation and common presentation of the multiple sclerosis. For expert,
So I think if I'm understanding the story correctly, you had identified the suspicious MRI lesions many years earlier. But sometimes, perhaps, if the patient has never had a clinical episode, we can't really apply our typical diagnostic criteria. So the last revisions to our diagnostic criteria in 2017 would insist that you've had at least one clinical event. If this patient had had an event, the patient would meet criteria for MS because there were periventricular and juxtacortical lesions and oligoclonal bands. That would really be all that's required. You also demonstrated a change on the MRI over time, eventually spinal cord lesions. The only other comment I would say is what's changing in our world is we're revising the diagnostic criteria to allow someone like this to be diagnosed with MS much earlier. To say we don't have to wait for you to have an obvious clinical attack if you have these imaging abnormalities, including central vein sign. One might argue this patient in the future could be diagnosed early and perhaps put on a disease-modifying therapy, which in turn perhaps would reduce the risk of seizures, for example. So I think as we had already discussed, it was atypical for pure epilepsy, and so or sort of idiopathic epilepsy.
It's atypical for pure mesial temporal epilepsy, but she's got a long history of focal seizures that remain focal that are worsening with control over time. So I'm not sure that the MS explains her epilepsy in the absence of a clear lesion near the cortex where you would expect her to have a focus. And I'm a little bit concerned about her temporal tip not being normal. So I think one needs to, I mean, she's complicated, right? And the nice news is she's an adult, so she's out of my clinic. But I would be concerned about an operable lesion to go after in her.
Not to belabor too much, but for instance, we were never sure why MS patients would have a higher incidence of epilepsy because we traditionally thought of MS as only in the white matter. But our recognition is that that's incorrect. And Charcot told us that these are focal lesions in the white and gray matter. Obviously, juxtacortical lesions mean there's been some inflammation and demyelination just below the surface of the cortex. And we're learning actually MS patients typically have gray matter cortical lesions as well. We just are not very good at seeing them on MRI. So I don't know if it's true or not, but maybe this patient's worsening slowly corresponds with the fact that you are not able to officially diagnose the patient with multiple sclerosis for many years, and thus the patient was not being treated for multiple sclerosis, though time has said that's really what this patient had all along. So I don't know if that connects it.
So then that gets the question is what is the natural history of epilepsy in patients with MS, and does the expression of the disease wander? Does it wax and wane with the activity of the lesion?
We need to collaborate and find this out. We need to figure this out. Well, I'll be honest, even though the literature says that there's this increased incidence of epilepsy in MS, in my practice, I have very few patients with epilepsy. I mean, you and I maybe share one or two patients in our career where they have MS, but I've also sent to epilepsy. And I wonder if it could be because in the modern day, we have such highly effective therapies for my patients with MS have almost no clinical relapses. Their MRIs remain completely stable. So it might indirectly say, wow, maybe effective treatment of multiple sclerosis does in fact have an impact, but I don't know.
But my recollection, which is based on no data, was that the seizures in MS were a later phenomena, as opposed to someone whose onset with the epilepsy is concurrent with the diagnosis of MS. Because she presumably her epilepsy onset is older, but in her 20s, but that's when the MS onset presumably occurred, maybe late teens. But the epilepsy has been the problematic issue for her, and the MS has not been. So my bet is, well, it could be you would like to explain everything by one phenomena. I think she's got lice and fleas. I think she's got two things going on. And
See,
I
it's
think
funny because the first case I thought was, well, these are just two unrelated things. Occipital lobe, I don't know what it is, and MS has nothing to do. In this one, I'm more convinced they could be connected. In fact, there is a concept now we talk about in MS. We talk about the MS prodrome. So we recognize, let's say some date somebody is diagnosed with MS. If you then look at their history, before their diagnosis of MS, we've documented that they have much higher utilization of healthcare resources, whether it's for mood disorder, non-specific symptoms, and then maybe things like this, where there's been this sort of
new onset refractory epilepsy.
Exactly as now.
See?
I'm going to add it to the list.
Add it to the list.
I'm adding it to
add
the
it to
list.
the PDR.
But I think what it just tells us is we often don't know. In other words, MS diagnosis can elude us for many years. I mean, some people just present and we're like, well, it's obviously MS, but we are discovering patients like this one that they have sort of maybe not what we expected it to be, but it turns out to be MS, which simply means I think the clinical spectrum is broader than we used to realize.
So can
But
I add a point?
I would also.
Yeah, I need to add a point to just we can merge headache with the epilepsy and MS. So this patient, as I had understood, she started her first presentation as being diagnosed as migrainous patient. And that's why she did MRI. So she was diagnosed first, and this is reported to be 38% of patients with MS could present as the first presentation as headache or migraine in females. So that's why she was investigated doing MRI, and that retrograde, you said that it was, you can say that it was radiologically isolated syndrome, right? But we have to just follow the patients with headache, like this patient. She's diagnosed as migraine, and then she's epileptic, the first presentation that we saw, right? She was missed as a migrainous patient. And then now she had this diagnosis fulfilling the criteria for MS. So my point is, so we don't have to miss the headache as a first presentation of MS, like this patient, right? Thank you.
Yeah, I would also argue, though, that what's debilitating to her is her epilepsy. And she's got a focal epilepsy that is bad. And I don't think the other issues going on dissuade you from considering a surgical option in her. So I would proceed with an FDG PET scan. I would try and, if you can, capture other seizures to make sure they're all similar, so it's not multifocal. And I would think very seriously about doing additional imaging, and I would consider her to be a surgical candidate.
MS has many symptoms. Migraine sometimes come in 10%, and epilepsy come in 5% of cases. This temporal lesion, I think it is such as like a neuronal migration disorder, and she has family history of epilepsy. So I think she has two pathologies, MS and neuronal migration disorder. So I agree with you. This is the ideal thing, I think so. Thank you.
So thank you. So we will proceed for PET MRI co-registration and try to record another ectel. And if the patient is still drug-resistant epilepsy, it's already fulfilling the criteria, and we can prove that the seizure from the left, as we appeared in the semiology, we can proceed to left temporal lobectomy without seeing a lesion in the temporal lobe?
Well, I think the left temporal lobe is not normal. That would require further double inversion recovery imaging, and I would do an FDG PET.
So, and no rule for starting DMD in spite of MRI is typically MS and the oligoclonal band is positive. No rule for DMD.
Start. Please start.
We need to. The patient has MRI fulfilling also the criteria of MS diagnosis. And the CSF oligoclonal band is positive with high IgG index.
Yes.
Does this patient need adding drug disease modifying treatment as at
well, yeah. So I agree. Even if what you say, as you formulated it, you say, well, this is two different. I think this patient clearly has multiple sclerosis. So,
but clinically presented by drug-resistant epilepsy and SETIT.
To me, it doesn't really matter because you have both dissemination in space and time.
Yes.
From an imaging standpoint and the presence of oligoclonal bands. And so you're absolutely right that many people with MS are getting identified because they get an MRI for another reason, because they had headache. Yes. Maybe they had a concussion. And again, it's exactly as you said, this concept of a radiologically isolated syndrome. As I said, because of this exact issue, the next revisions within a year for MS will allow us to simply call that MS. There was a time, as you know, if you had only one clinical episode, you could not be called MS. You'd have to have two. Then we said, oh, that doesn't make sense. Why don't we have a clinically isolated syndrome? Now you can have one episode, but we recognize, and RIS is just a natural evolution of our understanding. So I would not hesitate to start an MS therapy for this patient, whether or not it has anything to do with the epilepsy.
Which one?
Well, I mean, you have to have another lecture on MS disease-modifying therapies. Any of them, except maybe not beta interferon, which
I suggest rituximab, please. Rituximab.
Well, so anti-CD20 agents or B-cell therapies like rituximab in the U.S. are extremely common. Again, this is a different topic, but in the United States, half of all Americans on MS treatment are on an anti-CD20 agent. So that's much more than in other countries. In the US today, like we just flew over, I told someone they have multiple sclerosis right before we left, but a newly diagnosed person in the United States with MS, 2 out of 3 times they're placed on anti-CD20 agents. So that's a very popular strategy in the US. But again, probably independent of the epilepsy story. It's a very, I would treat.
I think it's worth, in these situations, probably trying to treat the MS first before removing brain tissue. Only because, we've been exploring the possibility that these MS medications might help epilepsy. We've done clinical trials of natalizumab in drug-resistant epilepsy with this idea that the inflammatory state is important for some patients with epilepsy. So why not let the MS treatment start first and then see if it's all possible for this patient that it helps the seizures rather than jumping straight to surgery. That's what I would do, but
okay, I hope next year to give you the follow-up.
Thank you. Dr. Gillard, you mentioned the natural history of epilepsy in MS. It is very important in this case because all the cases we see in MS with epilepsy, good responders to immunotherapy in very small doses. It is rare to see an epilepsy in MS with this resistance. Second thing, I hope to make another investigation for vasculitis or the colloid disease. In this case, at least the mirror image in the oligoclonal band. You see the oligoclonal band in the serum of the patient.
Type 3.
And they may make the kappa-free light chains again because this is maybe, as they say, it is very rare to see a very resistant case like that in MS patient. Thank you.
Okay, thank you. Thank you, Ahmed.